Hello, everyone. Welcome to another exciting episode of Voice of Dreams brought to you by Cyber Kings India. Myself, Shivani Shivadas, Community Executive and Content Creator from Cyber Kings India. Today, we have a truly inspiring guest joining us, world's first PhD holder in the ultrasonography of the gastrointestinal tract ulcer diseases. Please join me in giving a warm welcome to Dr. Vikas Leelavati Balasaheb. Welcome, Dr. Vikas. It's an absolute pleasure to have you with us today.
Thank you, Shivani.
Thank you. So, your work has revolutionized the use of ultrasonography in diagnosing gastrointestinal tract diseases. So, could you share your journey in the field of gastrointestinal sonography? What motivated you to pursue this specialty?
Thank you very much. It's a really nice question. I remember one case that, and I remember the date also, 18th January 1996. One patient came in the afternoon at around 3:30 p.m. and the referring surgeon was interested to know about the pancreas status because that patient was having postprandial vomiting. I scanned that patient, but I could not found the pancreas because the overlying stomach was full of food and fluid residue. So I requested that patient to come the next day morning, nil by mouth. Next day morning he came at 9:30 a.m. But I found again the stomach was having a lot of food and fluid residue. Then I asked the patient, I told you to come NBM, why you had a breakfast in the morning? He said, no, sir. Yesterday I had a lunch when I came to you. Before that, I had a lunch, and after that, I haven't had anything. Then I thought, why his stomach is not emptied in the scheduled time, that is within the couple of hours. Then I scanned the anatomy of the stomach and found there was a gastric outlet obstruction due to small scarred duodenal bulb. That is the first part of the duodenum, and that was due to the chronic duodenal ulcer. And that was my first case of the ulcer disease on the ultrasound. I tracked that patient laterwards, and I found that the gastroenterologist did the endoscopy, and he confirmed my diagnosis. And since then, I tried to locate and evaluate each and every patient for the stomach and duodenum, and also all the small intestine and the large intestine. And each time I was as there was no any textbook available which was elaborating sonography of the ulcer disease. I have to be very particular to get the feedback and to update myself. Then to be frank, I have literally attended more than thousands of endoscopies and surgeries just to confirm my diagnosis, because feedback is your unbiased teacher. When you get critics from the referring doctor, you will never do that mistake again. And so after that, I was taking the patient to the endoscopist, Dr. Rajesh Dharamsi, and he used to tell me that whatever you have written is right, whatever you have written is wrong, you have to update yourself. And every time I was carrying my sonography images and my report, and I used to update myself. He used to tell you have written ulcer at the posterior wall. No, it's along the anterior wall. You have written there is an ulcer, but no, there is not an ulcer, etc., etc. And after that, I updated myself, and I make sure that I will not repeat my mistake. That's all.
That's really great, sir. Really great. And as the world's first PhD holder in this field, I can imagine the road wasn't easy. So, what were some of the biggest challenges you faced during your research, and how did you overcome them?
I told you just now that as there is hardly one small paragraph in one of the textbook of the radiology. There is a small paragraph of the peptic ulcer disease. And so to get the confirmation, I have to take the feedback from the surgeons and endoscopists. So I had literally attended more than thousands of endoscopies and surgeries, and that helped me to come to the conclusion of the ulcer disease. It's a five-layer pattern of the gastrointestinal tract, then the penetration of the ulcer, and helped me uh, draft and conceive the Dr. Vikas Leelavati's classification of the uh, sonography of the ulcer disease.
Your method has potential life saving implications, especially in predicting impending perforations in gastrointestinal ulcers. So, could you elaborate on the importance of early detection and how your system improves patient outcomes?
Great. See, the gastrointestinal tract anatomically it is having four-layer pattern, but on sonography it is having five-layer pattern, and ulcer is created from the inside, that is on the innermost layer, that is mucosa, and the two strong barriers are present in our body. One is mucin, which is a chemical barrier, and the muscularis externa, it's a mechanical barrier which helps to prevent the ulcer formation and ulcer penetration. Mucin prevents in ulcer formation, and muscularis externa prevents in ulcer penetration. While doing the sonography, you can see the five-layer pattern, and if the ulcer is eroding the first layer, that is innermost mucosa, that is superficial ulcer, then while going deep, that is the submucosa, then muscularis externa and serosa, and all these layers can be, we can see the depth of the ulcer and the width of the ulcer. If the ulcer is reaching up to the muscularis externa, you can label it as an impending perforation. And if it is reaching beyond the muscularis externa, the serosa is very easy to perforate. So that time it's a perforated ulcer. So while doing the sonography, you can very well uh, sure that the depth of the ulcer and which layer it has penetrated, and what will be the next move of this pathophysiology.
So, how do you face any controversial questions in any international conferences, especially regarding perforated ulcer disease?
Yeah, it's really a good question, and I was facing much challenges during the international conferences, especially uh, in the gastroenterology conference, because in my lecture, few slides are showing that the ulcers are uh, either not visualized on the endoscopy or visualized but not perforated, and I shown on the ultrasound that the ulcer has been perforated. I remember one case, for example, the patient admitted yesterday at around 11:30 p.m. Then the next day morning, 8:30 a.m., X-ray test was taken. X-ray test was showing mild pneumoperitoneum, but the patient was now not having any guarding or rigidity. The physician performed upper GI endoscopy, and on endoscopy he found the duodenal ulcer, but that was not perforated. And uh, after this endoscopy, he repeated the X-ray erect abdomen, and the amount of pneumoperitoneum was same. So he requested me to check for it whether there is any small bowel perforation. I did sonography. I performed gastrointestinal tract sonography. I checked all small intestine, large intestine, but there was no any perforation. Then I went back to the duodenum, and I found there was a small perforation of size around 2 mm. And on my sonography, I recorded video, and that was showing fluid leak and air leak. So the surgeon perforated the surgery, and I was present within the operation theater, and my diagnosis was confirmed. And after listening this slide and my narration, many questions ask how it is possible, and I gave the explanation that when you perform the upper GI endoscopy, you push air, and when you push the air, the perforation might have been masked because of the overlying fibers. That's all. Thank you very much.
And did
Did any doctors at an international level ask you whether surgeons operate solely believing in your sonography reports, or do they prefer to confirm with CECT or CEMRI reports before planning for a surgical management?
Uh, yes. I must appreciate my colleagues, but the fact is, over the period of years together, I think I have gained sufficient um, trust within them, and yeah, many ask me at the international level you uh, whether your sonography reports are widely accepted, and whether the surgeon performed the surgery without going for a CT or MR. I said yes, proudly. I am able to gather with that much trust. Thank you.
So, in your opinion, how has the role of ultrasound evolved in the diagnosis and management of gastrointestinal ulcer diseases?
It's a really good question. The sonography, which is very cheap, very very much repeatable. It can be done on the bedside, bedside type, uh, and it is friendly with the patient, and it doesn't have any claustrophobia, and it doesn't have any risk of the radiation. So sonography should be the first choice for this gastrointestinal sonography. Of course, with the it is see, the sonography is purely operator dependent. So the operator, that is the radiologist, should be well versed with the sonography of the gastrointestinal tract.
I'm sure there are countless success stories from your work. We would like to hear a specific success story that changed the course of treatment for a patient.
Uh, Thanks for this question. I remember one particular case where I changed the changed the management from surgical to medical, and that was helpful for the patient. One case, uh, he was a 69 years old male. He was residing with his son in the UK, and on the 12th midnight, that patient was having severe epigastric pain, and he got pulseless. And fortunately, the ambulance came, and within the ambulance they revived that patient, and the patient was taken to the hospital. They performed the contrast CT scan and found it's a retroperitoneal huge mass extending from the right renal hilum to the left renal hilum, and it is encasing the all major vessels, that is aorta, IVC, SMA, SMP, and both renal vasculatures. On the 17th August, the CT scan was repeated, and the findings were same. So they confirmed the diagnosis that it is a retroperitoneal sarcoma inoperable. On 18th August, they flew back to India. On 19th August, they came to the hospital, and the referring surgeon referred that case to me for to get this biopsy done to know the type of the malignancy. I prepared everything for the malignancy and found that it's not a malignancy, it's a big hematoma. So for that hematoma, I suggested surgeon not to operate, not to take the biopsy. He agreed with me, and but he said, let's have a proof of your diagnosis. You know, the UK people, they don't issue the films, they issue only the report. So on 19th August, that patient again underwent in contrast CT scan in our hospital. I requested the CT reporting radiologist to report it as a hematoma, as it is seen on the ultrasound. They said yes, it's fine, we will report it as a hematoma. But after performing the CT scan, they came to me and they told me that no, it's a enhancing mass lesion. We can't report it as a hematoma. They reported it as a inoperable malignancy. Then I requested surgeon to believe in my diagnosis. He said yes, I believe in me. But the patient then went to another two hospitals. The same story repeated, and nobody was listening to me. As a couple of CT scan from the UK were confirming it's a inoperable malignancy, and two CT scan from Pune, they are again confirming that it is a inoperable malignancy. One more thing, the endoscopic ultrasound was also performed, and that also reported as a inoperable malignancy. And then I contacted the patient, and I told that I requested him that please give me 1 month so that we can avoid this surgery. There is no, one hospital has planned a surgery on me, but they requested a table death consent, so we are thinking on it. So I told them that it's a if they are asking for the table death consent, let's wait. It's not an emergency, and I requested them passionately, and they felt my feeling. They agreed with me. I requested my surgeon to start the medication for the hematoma, and I requested that patient to come for the follow-up sonography after 1 month. After 1 month, when that patient came, the 25 centimeter mass was regressed to 22 centimeter, and patient was also feeling good. I told the patient that yes, we are on the right track. Just come for the follow-up every month, and every month that every follow-up, the mass was shrinking further without any complications. And after 6 months, the 25 centimeter mass was completely vanished.
That's really inspiring, sir.
Yeah. See, one CT scan report can be wrong as a human error, but the 4 CT scan reports cannot be wrong. Then I found what made the radiologist to report it as inoperable malignancy, and I found that the mass was enhancing. That is, the contrast was seen within the mass. When the mass is having the contrast, it suggests that it's a tissue and which is enhancing. So it goes in favor of malignancy. But I found that, but I thought that this contrast must be from the first CT scan which was performed in the UK on the 5th August 2009, and that was true. On every next CT scan, I requested the reporting surgeon, please check the HU value, that is Hounsfield value of the plane and contrast CT scan, and that should be same, and it was same. So I told them that the contrast in enhancing contrast which you are seeing, that was from the first CT scan which was performed in UK on the 5th August. So this was a case which changed the diagnosis and changed the management from surgical to medical. That is exactly opposite to 180 degree. Thank you.
That's really inspiring, sir. And speaking of your work, tell us about your classification of type 7, which may save emergency surgeries or surgeries by exhibiting sealed perforations of an ulcer in the gastrointestinal tract.
I remember multiple cases where I saved the surgeries, and see, while you perform the emergency laparotomy, that patient should have a guarding rigidity, then the air under diaphragm, and the pyoperitoneum, that is pus in the abdomen. So I found in many cases that the patient is exactly suitable for this emergency laparotomy, but on ultrasound I found that the perforated ulcer has been naturally sealed by the omentum. Omentum is nothing but an abdominal fat, and it is also known as a policeman of the abdomen. That is, whenever there is something wrong, this policeman of the abdomen, the omentum, go and patches the perforation. And that was the case in every surgery which I avoided on due to my sonography reporting. And I found that the omentum has already patched this perforated ulcer, and they just consult the patient with medication, and without surgery the patient become well within a couple of days. So I avoided the surgery. So this type 7 classification is very important. Thank you.
All right. So could you please elaborate on type 8 reverse ulcer disease of your classification, sir?
Oh, it's first time in the world, and I'm very much proud of this ulcer classification. You know, the ulcer in the gastrointestinal tract starts from the inside to out. But I found a few cases where the ulcer has been started from the outside to in. It is very unusual to to explain, I would like to elaborate one case. She was a 41 years female patient. She was having a 80 cc abscess in the left lobe of the liver, and I scanned that patient in the afternoon around 4:30 p.m. and I asked that patient that you should undergo a few blood investigations uh, to confirm that you will not bleed during the procedure, that is PTNR and platelet count, and ask the patient to come next day morning with the all these reports. The patient didn't turn up for at least 4 days and on the fifth day she came from the ward and she was very much fresh and she was insisting me that you I should convey this surgery people to discharge her. I told her that yeah, I will suggest, but let me have a look at. I scanned that patient and I found that the left lobe liver abscess, which was earlier 80 cc, which that was remaining only 10 to 12 cc, and with some air bubbles within. Asked that patient whether someone has performed the aspiration by putting the needle or something like that. She told me that no, nobody has performed any procedure on me, but still I feeling the better. Then I thought where this abscess has been gone. Then I scanned that patient very particularly, very meticulously, and found that the left lobe of the ulcer first. See, abscess itself is an irritant. So I found that abscess has irritated the abscess that abscess cavity margin, then the liver capsule, and that came out of the liver and in outer layer of the stomach, which is adjacent to the left lobe of the liver, that was eroded first. That is, serosa got eroded first. Then the mechanical barrier, muscularis externa, then it got irritated, and finally that abscess drained into the gastric cavity by perforating the innermost layer. So, to be frank, then God has performed the irrigation drainage of this abscess, and that was without any complication. I asked the patient whether she underwent any loose stools during this course. She told me that yeah, next day evening she underwent these loose stools. As the abscess got perforated within the gastric lumen, then the reverse osmosis played well, and the stomach was washed by the indigenous secretions, and the abscess was thrown out of the body through the loose motions. So this is the reverse ulceration. Usually ulcer is from the inside to out, that is mucosa to serosa, but here the ulcer perforation was outside to in, that is serosa to mucosa. So this is very unique. This is first time in the world anybody has reported.
All right,
Thank you.
sir. So great to hear, sir. And what advice would you give to aspiring clinical research scientists interested in gastrointestinal sonography?
See, I told you that this stomach, duodenum, and after that small intestine is 18 to 22 feet, and large intestine is 7 to 8 feet, and it is usually filled with fluid, air, food, and stools. And so the peristalsis plays the vital role. If you want to diagnose anything hollow organ, that has to be distended with the food, with the fluid or indigenous secretions. That distension you can make either by turning the patient from the right side up to left side up, or you have to wait for the peristalsis. And so the aspiring radiologist for the gastrointestinal ulcer disease, you need to have a lot of patience. Thank you.
Yes. That was a really great advice from your side, sir. Looking ahead, how do you see the future of gastrointestinal imaging evolving, especially with the advancements in technology and research?
Oh, see, initially this sonography was a static study like X-ray and CT scan, and that later evolved to the dynamic study, that is a real-time sonography. But while you want to put this study in the artificial imaging or machine learning, that has to be static study. So I want to get back to the old strategy, that is static ultrasound, but with some or finest touch. So I'm in discussion with biomedical engineering and uh, information technology people that it should be used as a static study. See, artificial imaging can be used in a static studies like X-ray, CT, and MR as it is a static study, but cannot be used in ultrasound as it is a dynamic study. So I want to make sonography in a static study so it can be used worldwide, hassle-free, and within a less period of time. Because this gastro ulcer disease, you need to have a lot of patience. Initially, I used to take a lot of time for the every patient, but now with artificial imaging, it should be reduced to less than 1 minute. I guess so. Thank you.
All right, sir. All right. So, collaboration is the key in any field, especially in medical research. So, how important do you think collaboration is in advancing research and clinical practices within gastrointestinal sonography?
Yeah. The collaboration with the biomedical engineering and the IT people, that is machine learning and artificial intelligence, that will play a major role in the collaboration because it will reduce the imaging time and it will help you to get a better outcome in a short period of time. So it's a long process, but I hope it will be a success. Thank you.
Sure. So, for anyone pursuing clinical research, especially in gastrointestinal sonography, what are the key skills or qualities they should focus on developing?
See, I told you that there is no any textbook or any paragraph which teaches you that sonography of the gastrointestinal ulcer disease. I remember one case when I was pursuing my post graduation in radiology. One patient came to my teacher and that patient was having severe epigastric pain, and my teacher performed the sonography and the report was normal. The liver, gallbladder, spleen, pancreas, and both kidneys were normal. So the report was normal. So I asked my teacher why we can't explain the pain of the patient. My teacher told me that we have been taught for the solid organ sonography, that is uh, liver, spleen, both kidneys and all this stuff. We haven't taught about the whole organ sonography. Then I asked my teacher where this patient will go and get the pain explained. He told me that he will go to the gastroenterologist. He will perform the endoscopy. Then I literally went with the patient, and the patient went to the gastroenterologist. He performed the endoscopy and found that he was having a duodenal ulcer, which was impending perforation. And so after that, the treatment was started and the patient's pain was relieved. Then I came back to my teacher, and I asked that. Ask him that why we can't report an ulcer. He told me that we can see what you know, that is what we have learned, and as it whole organ sonography is not at all in any textbook, we don't know how to see that. So that's why I write in my every lecture, my last slide is, you can see what you know or what you can imagine. So that I imagine that this patient must be having some gastric outlet obstruction. Then I told you that about my first case of chronic duodenal ulcer causing scarring, stricture, and leading to gastric outlet obstruction. Thank you.
Great, sir. As a leader in healthcare, what message would you like to convey to those entering the field of innovation and patient care?
If you want to do some outstanding work, then the feedback is your unbiased teacher. When you get a feedback from your referring doctor, whether it is a surgeon or physician or general practitioner, and when you get the feedback, you will get to know that what mistake you have done, and you should be firm that you will not repeat the mistake. So feedback is your unbiased teacher, and the patience. And you should be firm with your diagnosis, which I told you that I was very much firm when 4 CT scan reports were against me, and I was still firm that no, it's not a malignancy, it's a hematoma. So firmness with your diagnosis is very a pivotal role. Thank you.
All right, sir. Great. And you have achieved so much in your field, Dr. Vikas, sir. Balancing the demands of your professional life with personal well-being must be a challenge. How do you manage that challenge? And how do you manage
Yeah.
that balance?
Uh, for that, you need to keep your humor alive, and you should love what you do. That's the key for me. That's all.
All right, sir. So you hold intellectual properties in the field of gastrointestinal sonography. Could you share insights into these innovations and how they contribute to advancements in medical imaging and diagnostics?
Yeah. Up till now, there was only two classifications of the ulcer disease which were available in the textbook or in the medical history. That is, one is surgical classification and another is endoscopic classification. There is no imaging classification available for this endoscopic on this ultrasonography of the ulcer diseases. And I found that out of my 20 types and subtypes, only 4 will need immediate surgical intervention. Rest, all 16 classifications can be managed with the medication or with the interventional radiology. So that proves that it's the first time in the world and it's very famous in the American Medical Association.
That's really fascinating, sir. And thank you so much, Dr. Vikas Leelavati Balasaheb, for sharing your insights and experiences with us today. Your contributions to medical science are truly remarkable, and we wish you all the success, sir.
Thank you.
Thank you, sir. And to our viewers, thank you for joining us today. If you would like to learn more about Dr. Vikas Leelavati Balasaheb, be sure to check out the links in the description below. Stay tuned for more inspiring interview. Until next time, take care and bye.